So we're going to look at the stress profile. So some people will call it stress profile, some people call it stress assessment, or psychophysiological stress profile. It's all similar names. So a lot of, we want to look at what the reason is that we're doing a stress profile and what it is. So basically we're going to be measuring many different things at the same time. And for the most part, I tend to do the peripheral modalities by themselves. Some people would also include EEG with the stress profile. I usually don't do that. I would do, if I'm doing EEG with a person, I would do a different kind of assessment with that. So these are some of the things that we might measure. Here they're listing blood pressure. Many times people don't do blood pressure with the stress profile, but you have electrodermal activity, which is referring to sweat. And the funny thing with electrodermal or sweat activity, there are many different terms that are used for very similar things. So for measuring changes in the amount of sweat on the skin, you have electrodermal activity, you have electrodermal response, you have GSR, galvanic skin response, you have skin conductance. All of those terms have to do with the sweat activity. Then you have the surface EMG. And by the way, when you see the S in front of the EMG, it just means surface EMG. So sometimes you'll just see it listed as EMG, and sometimes you'll see surface EMG or just the S in front of the EMG just means surface, that we're not using the needles. That would be for diagnostic purposes, which we talked about. Then you have skin temperature, respiration, and what we're looking for is what all of these levels are doing in a resting condition. So that would be like your baseline. Stressor condition. Here they're saying functional movement, but I consider functional movement maybe something different than what would be included in the stress assessment. Right. That's more of a dynamic assessment, especially for EMG. You might use it for other modalities, but mainly you would be interested in movement with EMG or in different postures. And recovery, which is important. So the interpretation of the values, it's saying requires that the professional reference to published norms or your own database. So you're looking for whether the readings even in baseline are within what you would consider normal range, or maybe they're higher than what would be expected or lower than what would be expected. And then also what happens under stress conditions and recovery conditions. I've seen it many times, some people don't do stress assessments, and then they just pick what modalities they're going to work with, maybe because the textbook, maybe they look in the textbook and it says for headache you do EMG and temperature, and so they start doing EMG and temperature. And then also, I've also seen where maybe somebody does a baseline, just recording, not doing any stressors or anything, and they see, okay, the EMG is only 2 microvolts, so they have no problem with EMG, so they don't decide to use EMG with the person. But if you put the person under stress, the EMG goes up.
Yes.
And then when you say to relax after the stressor, it doesn't come back down to baseline.
Right.
But if you just have them passively sitting, you would miss that altogether. So that's another reason why you do it in this way. So these are some things that you want to consider that are important when you're doing a stress assessment. So the person that's conducting the profile, we talked about the person effect yesterday. If you have someone that's really mean that's doing it, or you have somebody that's very kind, and you need to be careful sometimes when you're doing a stress assessment that you don't start doing therapy already. because the person may start to relax more than they normally would just because of how you're talking to them, and you may start without even intending to talking about their breathing and their muscles and relaxing and things like that. So you want to avoid those kinds of things because it can affect the results. The instrument, making sure that it's calibrated properly, making sure that it's set properly. Things like the filters, you want to make sure you know, do I intend to use a narrow filter or a wide filter? Is my system calibrated? It's like you're going to weigh yourself because you want to lose weight and you forget to zero the scale, and you get on and you think, oh great, I'm losing weight, but it was off and it was 3 pounds below zero, so you didn't make any progress. You just need to set the scale properly. The sensor placements, and as Dr. Palacios mentioned, the skin preparation is very important, and how you attach the sensors. All of those things are very important, and differences in that can affect your results, so you want to be careful. The environment, so the temperature of the room. I was mentioning here, while this morning I was feeling cold, again, just like yesterday it was cold, so I checked. I wanted to make sure it wasn't just me, so I turned on the instrument, and I saw that the room temperature was 70 degrees. So I went and I asked if she could turn the air conditioning down, and she did. And I continued recording, and the temperature went up to 74 degrees within a few minutes. So I was just experimenting with it. The graph is there. And I put an event marker at the time when when she turned the air conditioning down. So just that, the temperature changed already 4 degrees within a few minutes. So if I was doing a stress assessment and the room temperature was uncomfortably cold, the person's hand temperature would probably be much lower than it normally would be, because that is a stressor. Lighting, sound, like in this room right now, we have some construction sound going on and things like that. So that could be affecting if we were doing a stress assessment here. And electrical artifacts, so making our readings higher if the instrument is picking it up. Drafts, we talked about the air conditioning vent, or if you have an open window, anything like that could cause a draft. Furniture. So if you're using a chair, normally most people would consider this, but if you had a chair that's very uncomfortable, that could cause a problem. Or sometimes even the way that the armrests are, and depending on the person's body, it may cause them to hold some extra tension. Let's say the armrest is too high or something, and they feel like they're doing this, so you might be picking up extra tension just because of the furniture, or if they have to look at a screen, where the screen is, that could also cause issues. Position, movement of the individual, eyes open or closed, whether they're sitting, standing, reclining, all of those things can affect the readings. Even the time of day can have an effect. So, with people with their internal clocks and so on, and how it can affect their body, their mood, and so on. What the person ate recently, if they just smoked a cigarette, those things can definitely affect it. Or if they just had one of our coffees here. Or if they came in drunk, anything like, all of these things are important. And these are other things that can influence what happens with the test. Your procedures, the equipment, the novelty of the stressor. So if you've used the same stressor over and over with a person, after a while it's not going to have the same effect anymore. And the type of stressor that you use can be very important. For one person, math may not have that much effect on them, and for that same person, talking about a real stressful event that happened may be much more meaningful to them and cause them more reaction. Relationship with the staff. So again, this is one of the reasons why you want to do the stress assessment early on before you start doing other work with them, because it changes. Once they start to see you as somebody that's helping them, and you're teaching them how to relax. Sometimes even just when they come into your office, they start to relax before you put any sensors on them, just because they're starting to associate coming there and seeing you with relaxation. This is talking about blood pressure, if we were using blood pressure with the stress assessment. Electrodermal activity, that's the sweat activity. It's showing, these are figures for resistance. So if you're doing resistance, which is like the opposite of the conductance. So most of the equipment, well, I know for thought technology equipment, it's only going to show conductance readings. For the J&J, which we were also using yesterday, you have the choice of looking at conductance or resistance measures. And so it's important to know that the direction of the change that you're looking for is opposite when you're looking at resistance versus conductance. So with more of a reaction response. So if you, let's say the person is startled or stressed, and the reading would start going up on conductance because there's more sweat, if you were measuring resistance, the reading would be going down. So like on your equipment, you're measuring conductance. So more sweat, the reading goes up, less sweat, the reading goes down. With resistance, it's the opposite. And that could also be a question that the BCIA exam would ask you about that. And the resistance is measured in thousands of ohms usually. So here it's saying ohms, but you may see K ohms instead.
It's different, the reading.
How's the conductance measured? I was confused about that.
Well, yeah, this is resistance.
Yeah.
Conductance is going to be measured in, they call either microsiemens or micromoles.
Okay.
So they first came out with the term micromoles, and it's basically ohms spelled backwards, but sometimes people started to feel like that was a little silly name to use, so they thought they would improve, and they made it microsiemens. But every time I in a class, when I say microsiemens, usually somebody starts to laugh because that sounds a little funny. But these are the units that are measured. Now, this one says the range is 2 to 100, but I don't know if I really agree with that, because the readings you can get much lower than 2. I don't know, what is your...
Well, in fact, higher than 100 microsiemens.
Really?
Yes. The scale is from 0 to 200 microsiemens.
And you've seen higher than 100?
Yes, for example, in adolescents, working with adolescents. And in one case, I have a child with 170 microsiemens.
Wow.
And this was because this child was with his grandmother. And his grandmother was with Alzheimer's. And nobody in the family knew. So it has all these dissociation problems, the grandmother, and the child used to live with that. So he was scared and stressed all the time, and that's the reason why he has this measure. So you can have more than
that's the highest
100
reading
and less than 2 microsiemens.
Right. And what reading would you consider to be somewhat high, like that you would feel that
reading? Well, reading in microsiemens or micromoles above 3 microsiemens is awareness or alertness or even attention. And we have to remember that skin conductance changes with attention, not only with arousal.
Right.
So above 3 microsiemens, it is attention, but it is not stress, not even arousal. About 7, 8 microsiemens, it is the beginning of arousal, and above 10 microsiemens, we are having now a real arousal response. up to 30 or 40 microsiemens, where you are talking about real arousal.
Like I've seen a few people that I've worked with that would be in the higher range of the people that I've seen have been around 30. And like one of them, I remember his hands would shake, and like when you shake hands with them, you can feel the moisture on their hands. And he was what you talked about coffee this morning. So he was he was in a car accident, but he also had chronic headaches, and he also had anxiety. And when we were talking, he came early for one of his sessions, and he said, "Oh, I'm going to go get some coffee. I'll be back." So he asked me if I wanted coffee, and when he came back, I said, "By the way, how much coffee do you drink?" And he said, "Oh, about 10 cups a day." And so maybe this is one of the things we need to work on. So like you said, there are many times that there are things that have nothing to do with just directly biofeedback that may need to be addressed. And you mentioned also some nutrition things that can be important that could be affecting what's going on.
We have been using 5 as a kind of a cutoff.
Well, here I have an example of the last week of a patient doing relaxation with skin conductance. He's with 1.20 microsiemens. After during the stress assessment, he had 50 microsiemens.
So it went from 1 to 50?
No, 50. He went from 50 to 120.
Up to 120?
Yeah.
Wow.
Yeah.
Wow. That's amazing.
0.20. Yeah.
Wow. Then you have heart rate, and it talks about some of the readings for heart rate to look for. Next is surface EMG, and some of the earlier work with not early work, but this is actually around the time when I started in Biofeedback 1984.
Jeff Cram, you mean?
No, well, I'm saying as far as this work, Jeff Cram.
Jeff Cram.
He did a lot of work in surface EMG, and he came up with a chart of readings that you can use as somewhat of a guide in terms of what would be normal readings. So for these different muscles, frontalis, masseter, and so on, and you see he's got the posture either sitting or standing.
Previous.
And then what would be average and elevated between 1 and 3 standard deviations. So it's somewhat of a guideline that can be used for those different muscles.
Do you usually do that? Do you have the patient sitting or?
For me, when I do a stress assessment, it's all sitting.
Right.
Now, part of what he was doing here is he also had something you call muscle scanning. What happens is it gives a nice graph, it shows a picture of the back, and it has color-coded the areas that are more tense and the parts that are within normal range and so on, and they show the spots that are more tense as the areas that need work. And it did a nice printout, and it would show if there were areas that had more tension than others, it would highlight them. But also another thing is that if you're not doing the test properly, it can give you false readings. So what would happen, let's say I'm holding like we have the EMG sensors that we've been using. I don't have it here now, but that's okay. So if you imagine, I'll just take this off for now. You have this part that has the sensors on it. This just has the connectors, but if it has the sensors on it, and now I'm going down the person's neck and back and touching different areas to measure the muscle activity there. But now, if I press lightly at one area, and then I press more strongly at another area, that's going to affect the reading. And so I may get a higher reading when I didn't press as strongly, just because the conductance is different. So so there was some, some possible places there where you might not be getting a totally accurate reading. So there's some user error possibilities there. And yeah, if you knew how to do it properly, you could get a pretty good reading, and it would give you some idea as to where you might want to focus in doing EMG work with the person. So for instance, if I find they have here 15 microvolts of muscle tension when they're supposed to be relatively relaxed, I know maybe I should do some work with the trapezius for that person to learn more relaxation. Then you have skin temperature, and here this is talking about some of the differences with the males and females. So I think somebody asked about that earlier. So that will be in the stress profiling section in the handouts. And respiration. Again, there are some differences, male versus female, that they're showing here. And we're looking for how fast the person is breathing. And these are some of the things that we're looking for. So the stress response pattern, which can be individual. And that's part of the reason why we're doing this. If we just go to the textbook and see what the protocol is, we don't get that. Sometimes I'm very surprised, and where I would think that the biggest thing I should work on with this particular person is EMG, but then I see their skin conductance. It looks like it needs more work than the EMG.
Right.
And going back to what some of us have been talking about, some of these situations where you have what you ideally would want to do, and then you have what you're stuck with, the situation you're stuck with, and you might have to make some adjustments. So for instance, it would be ideal to have many more sessions in most cases, and sometimes you don't have as many sessions as you would like to. So if you have in mind a whole treatment protocol that would address many different things, you may not get the chance to do so many. So like for instance, I know in some of the situations where you're doing work with in a place that does no fault, and you are supposed to get 12 sessions, sometimes you lose a person after 4 sessions. And so what I would like to do is spend those 4 sessions on the most important thing for that person. So at least they get something out of it. And I've seen situations where, I had one person that was in a car accident, and he had pain radiating all the way up his arm into his shoulder. When I was doing the stress assessment, he's sitting and I see his hand like this. And I didn't say anything, I just went ahead and did the session. Now, somebody might have said, you should tell him to relax his arm when you're putting the sensors. I didn't do it because this is how he's coming in. There's no reason for him to be doing this, but he's doing it. So I wanted to just measure what was there. And as part of the stress assessment, I put the sensors there. I had one set here and one set on his arm. And we measured, and the readings for his muscle tension in his arm was averaging about 22 microvolts or so. So I think I saw him after that 4 sessions. And within that time, his muscle tension got down to 4 microvolts. And his pain was gone. So when he came back, he was coming in the clinic to do other things. And I said, come in for your biofeedback session. He said, I don't need it anymore. He said, well, we're supposed to do 4 sessions. And he said, well, the pain is gone, so I don't need it anymore. Now, ideally, we should still do more sessions because, maybe he hasn't really learned so that it's not going to be a problem anymore yet, and he could use more practice. But for him, he got what he needed. And basically what was happening is he was just contracting those muscles so much it was causing the pain. When he stopped doing that, even though his level was at 4 and he should be able to learn to get to 2 or 1, the symptom was gone. So he didn't care that he was only at 4, he cared that his pain was gone. So he didn't come back anymore. But if I had decided that I should do skin conductance or temperature with him, I may not have gotten the chance to work on that. So there's, sometimes you see those things. So the pattern that that particular person responds, also the types of things that are more stressful to them. And then you can use that information to customize the plan that you're going to use with them. So you want to, based on the information you gather from the stress profile, to decide what modalities you're going to focus on, the sensor placements also, and these are, again, the things that we would normally include in the stress assessment.
Now the blood pressure, I haven't seen that. How do you?
I can show you that I have a blood pressure unit with me that I can show you, but it plugs into a USB port.
Okay.
And I'm not sure what version of the software you have. If you don't have the newer version, you might need to update your software. But what happens is it plugs in through a separate USB, and you can trigger it manually to inflate and take a blood pressure reading, or you can have it programmed where every certain amount of time it inflates and deflates and gives you a new reading. And another thing you can consider too is that could affect some of the other readings. So like when the cuff inflates.
Yeah,
it usually affects
blood flow or muscle tension.
Yeah, because even if you had someone hooked up and you just touched them, you know, if you just touch them on their arm, it's going to affect some of the readings, at least maybe skin conductance or something.
Would you usually put a set of sensors on one arm?
I put it on the other
on
arm.
the other.
And you can also measure other things like CO2, heart rate variability, and some people would also do EEG at the same time. You would use stressors that are mild, so you don't want to do something that's going to cause them to run out of the room or anything like that, or you know, really have a big reaction. If you're doing EMG, it can be helpful to do bilateral, especially if you're working, say, on the neck or the back, because you can then see asymmetries if they exist. And the asymmetry is defining, at least based on CRAM, as if you have a difference between the left and the right side of at least one standard deviation. Other places I've seen the 20% difference between the sides or more. So this is not the only way you can do a stress assessment, but this is an example of how you would do it. So a baseline of 3 minutes, then a relaxation of 3 minutes, and it's important that you're having the person relax without, in this case, without giving them specific instructions, or you're not guiding them through a relaxation. Some people do that, but I feel that it's not the time to do that yet. And then in this case, they're doing a mental math stressor. In the software that Thought Technology has, the built-in stress assessment doesn't do both of these. So it doesn't do a baseline and a relaxation. It just does a baseline, which also, I guess, would count as the relaxation in the beginning. Then you have a recovery, and instead of 3 minutes, they're using 2 minutes. So you have your recovery, then you have a personal stressor, another recovery. This is something I don't do, but in this case, this example, they say a hyperventilation challenge. I don't ask people to hyperventilate because I don't want them to pass out when they're working with me.
Or to have tissues.
Yeah, I mean, you have to also take into consideration the setting that you're working in. So there may be some things that I might consider doing if I was in more of a medical setting where I have doctors and nurses right there, and specialists and you know, seizures and things like that. That if I'm working in a setting that's more of a mental health setting, you know, psychologists and you know, that's basically it. I'm not going to do things that I feel like I might get in trouble and need a
You always have to ask what is the added value comparing to what risks are you taking.
Right. And then you have recovery and then debriefing. So the debriefing sounds very military, but mainly that's to explain what we did and the results
And it's
of it.
a great opportunity to engage the patient because
Yes.
the patient has seen the changes and get motivated for treatment and so forth.
Exactly.
The briefing is an essential part.
Yeah, and I see people actually get excited about the process from going through, showing the graph and saying, okay, this is when you were relaxing, this is when you did the math, this is when, and they see the reactions and they see maybe the lack of recovery, and now it makes sense to them why they're coming back and doing this training so that they can learn to improve those things. And also it can serve as a before picture, so that later on when you're looking at their data, you know, maybe they started out with a 77-degree temperature, and now you've been training with them, and they're coming in now, and their starting temperature is 90 degrees now. You know, and they can see. Whereas if you just start right in and doing training, they don't have that before picture, and they maybe say, well, I'm not any different than I was before. And sometimes the perception, you know, from day to day, they don't see the change. It's like when you have you know, a young relative and you haven't seen them in a while, you say, oh, you grew so much, and they're like, I didn't grow. You know, but you have the before picture, and now you're seeing them again, so it's a big difference. Here they're talking about the process. The person sits in a reclining chair during assessment. I don't necessarily agree about the reclining chair, because I want it to be a little bit more normal situation, and at work or play. Most people don't spend a lot of time sitting in a reclining chair. Now, if you're trying to encourage them to relax, a reclining chair can be helpful. Here they're talking about a range of different positions and tasks, but that's during a neuromuscular assessment. So that may be where you put sensors on the person's neck, and you might ask them to bend forward and come back up, or turn to the left, turn to the right. Those kinds of things would be more of a separate assessment, a neuromuscular assessment, rather than the part of the stress assessment. Here they're listing the sensors again, and possible placements for them, and you have all of this in your handouts. The relaxation instructions, this is one person's opinion of what the instructions should be. I find it important not to have the screen visible to the patient, except for if there's a specific task on the screen for them to do. In the software that I tend to use, the thought technology software, in the stress assessment that's pre-programmed, they have a task that is like a Stroop test. And for that task, it's on the screen, it's presented on the screen, but the physiological measures are not presented on the screen. So it's okay for them to watch the screen during that time. In fact, they have to do the task. But at other parts of the assessment, they would actually see the recordings on the screen, and it's not, I feel like you're defeating part of the purpose of doing the assessment, because now it becomes a biofeedback session. Even if you don't explain all of the details, people are smart, and they figure out, okay, I did this and it went up, and so, you know, now I'm not going to do that anymore, and now they work on trying to keep it low, and so you end up losing some of what you would have recorded, because now they have knowledge that they didn't have before. So I always have them not see the screen anytime it's showing their readings. So basically, I usually will tell the person, for the next 2 minutes, I just want you to relax. I don't go into imagery or anything like that. And also, it's important to tell the person, before you put all these sensors on them, that it's something to the effect that I'm going to apply some sensors to you to measure how your body reacts to stress. You don't feel anything from this test. There's no electricity going into you. It's only measuring things like your heart rate and muscle tension, things like that. And then I also tell them that I'm going to show them the results afterwards and explain it to them, so that I don't get a lot of questions during the task, because that can throw the readings off. During the part where you do the personal stressor, I have some disagreement about this. Some people ask the person to think about, imagine like it's just happening again, a stressful event. And then other people say, I want you to tell me about a stressful event. My opinion is I ask people to tell me about it because I don't know what they're doing.
They are thinking.
If they're just sitting there, I don't know if they're thinking about the stressful event. I don't know if they're thinking about their groceries or being on the beach or I don't want to be here. I don't know what they're thinking. And also, you don't know how long, if they're doing the task for the whole time or not. The other part of why I can understand why somebody might say only to think about it is because as they're talking, you could get some artifact. So if I have sensors here and they're talking, with the expressions of their face, you might pick up some muscle activity that's not necessarily stress, but it's just mechanical from expressions. And you also, even if you put it on the trapezius, some people talk with their hands, or if you put it here, so you can get some artifact from the talking. So you want to take that into consideration.
Can I ask you what the soldiers, the trauma and so on?
I don't ask them to tell me about their trauma. So I'm very careful when I said think of a stressor situation. I specifically tell them not to discuss a wartime experience because for some of them it's very vivid, and I don't want to have a situation where, but they have plenty of normal everyday stress. Problems with the supervisor, problem with their wives or husbands, problem, and problem with the system, and makes them very frustrated, and their anger level I never have an issue with it.
And so the placement of the sensors, you can think about that in terms of where you might put the sensors that maybe you don't have as much of an effect there. But what I do is I just take that into consideration and I'm watching the person as they're talking. So if I see them talking like this and I had the sensors on their arm, I'm realizing that I'm going to see an increase in their readings that had to do with them using their hand. But now when they stop talking about it, if the reading is still elevated, that's still meaningful. Even though the elevation while they were talking is not as meaningful, the lack of recovery is still meaningful.
Right.
Well, yeah, we want to see what happens. We want to see what happens.
But it would be normal that they would get a bit worse during the session.
Sure. We're not expecting that it's just going to be flat during the stressor. So let's say, for instance, if there's some increase in muscle tension during the stressor, when they finish talking about it, we want to see, does it come back down or does it stay up? Now, if it comes back, first of all, how much it goes up is important. So if they go from, let's say for EMG, from 2 microvolts to 4 or 5 microvolts, and then they go back to 2 microvolts, that's no big deal. But now if it goes from 2 microvolts to 25 microvolts, and then when they stop talking about it, it only comes down to 20, that's important. That's important. That's something to work on. Many times you see things that are not what you would expect. So just sort of a standard thing that you would expect is baseline, the readings are at least more normal. During the stressor, they go to what would look like a stress response. And it doesn't have to be for each modality, but for at least some of the modalities or one of the modalities, you would see this response, whether it's increased muscle tension or increased skin conductance, something like that you would see. And then during the recovery, it either recovers back to baseline or it doesn't. And you see that pattern in the other stressors as well. But sometimes you see something that looks totally opposite of what you would expect. Like you were mentioning about pain, and during a stressor, the pain maybe not being there. So many times I see elevated muscle tension in the baseline where the instruction is to just relax. And then I give them serial 7s to do, math or something like that, and the muscle tension goes down. And then when I say relax again, the muscle tension goes back up. So it was almost like it was a break from
Exactly.
from their normal
Yes.
condition.
Exactly.
It's a condition that shouldn't, it's not really normal, but it's normal for them. And so now they're distracted from
Yeah,
their normal
it's an
condition.
attention problem.
Yeah.
It's an attention
Yeah,
problem.
they are moving their attention to another
Yes.
theme, another subject.
Yes.
And you can prove that with,
Yeah.
with brain
Yes.
mapping also.
Yes.
So now when you
That's
take the
exactly
task away, they go back to that other condition that may not be good.
Because they focus attention in the condition all the
Right,
time,
right.
and they are measuring the condition all the
Right.
time. I feel good, I don't feel
Yeah.
not so good,
Yeah.
I feel better all the time, which is a nightmare, by the way.
Right.
Yeah.
So when you see those things, then you point out, okay, so it's like a chronic excess muscle tension, and that's something that you would work on with them to be more aware that they're doing it. And just this test alone is telling them that they can release the tension because they did it. You know, and now it's okay, how do I, one, tell the difference between when my muscles are very tense and when they're relaxed, and how do I gain control over both of those conditions? So that's part of what we find out, and that's why you wouldn't assume that would be the case, but sometimes it is, and they see it. You know, it's clear on the graph when it happens.
Yeah.
Okay, so we talked about explaining to the person about how to do the thinking or talking about a stressful situation. And again, I said I tell them to actually talk about it because I don't believe all the time that they're going to think about it the whole time. The other thing is when you do tell them to talk about it, often they will say something very short and stop. And then the rest of the time you still need them to keep talking, so you may have to ask them to elaborate on it. So for instance, when I was working with people that were in car accidents, I was asking them about the car accident. Tell me to describe the car accident that you were in. So some people, they said, well, I was at a red light and a car hit me from the back. And they just stop. So I say, okay, so after they hit you, what happened? You know, did you stay in the car? Did you get out? Were you hurt? You know, so then they start talking again, and then you know, you just wait until the time is finished. And the other opposite is that they want to keep talking and keep talking and keep talking, and the time to stop talking is there, but they're not finished with their story and they want to keep going. So you have to, in a gentle way, tell them that you need them to stop for now.
Right.
And when you finish with the test, they can finish telling you. And that's what I usually do, so that if they're not finished the story, they don't feel insulted that I didn't really care about their story. I just want to do my test, you know. So then after we finish, I say, so then you can finish telling me what happened now. So those are some of the things that you want to think about with the stress assessment. Let's see here. So you are looking to see if you have any elevated readings, if there are any asymmetrical. So if you're measuring left and right side, is the right side higher, or those kinds of things. And does it change more during stress? And also, does it return to baseline? So again, it's important, does it return to baseline? Not only how much is there a change to begin with. Then this is important to see what system or which physiological signal is changing, and is it related to the symptoms that they're coming in for. So if you have someone with anxiety, you may see more things related to their breathing or to their skin conductance or their temperature changing, or maybe even their heart rate. Whereas if you have someone with pain, you may be more likely, especially if it's muscular pain, you may see more changes in the muscle activity. And that also helps to make the case for why you're doing biofeedback with them, because if they see, oh, the muscle tension levels were high and they didn't recover well, and I have pain, and they're telling me if I relax my muscles that can help with the symptom, it kind of makes sense. And then especially when you work with them, if they see the levels coming down and if they are experiencing changes in their symptoms, it makes the whole thing make sense. And also, again, going back to a person just looking at the screen and not knowing what's going on, if they have that from the beginning, there's a much better chance that they're going to understand why they're doing it. And even looking for, while they're doing the session, okay, I remember when I did the test, my skin conductance was very high or whatever, and now as I'm doing my relaxation, I see it changing in the direction that they told me it needs to change in. So those are many things that I look for. You're also looking to see, are they able to relax without you guiding them through relaxation, just with, from the beginning. Because sometimes a person is able to relax okay, but it's just during those stresses they have a big reaction. So for instance, you might have someone who has, let's say, muscle pain in their upper back. They may have a job that during the work they're tensing a lot. But then when they come home and they're sitting on the couch watching TV, they're very relaxed. So it's not that they don't know how to relax, but when they're doing certain tasks, they don't know how to relax. So you may see that they can relax during this, but you see the reaction under stress, and you need to get them to be able to relax to an extent even during a task. You're not going to expect that as a person is lifting something, their muscles are going to be as relaxed as if they're just sitting on the couch. Of course. So you do want to see whether they're able to relax without instructions. And then the last one, for any people who decide that they want to make people hyperventilate, then you would see whether, when they hyperventilate, if it triggers a panic attack. I wouldn't bet against it, so that's why I don't bother doing it at all myself. And as I said before, you get to see how the person responds, which modalities tend to respond more to stressors, and how do they recover. So you might have some people that respond more to something that another one doesn't. Someone may have changes in their heart rate and blood pressure, another one has tension in their upper back and their neck. It's different for different people, and you may have a person who may respond first with one modality, and then if the stress continues or elevates, then the other modalities might also respond. So you can start to see some of those things. And what I see a lot when I'm doing the stress assessments is that when the person talks about a stressful event that was real for them, the response is much greater than it is for the Stroop test or the math test, because some people are very worried about performing, in front of somebody, so the math or the Stroop would be very stressful for them. But another person really doesn't care that much. They try to do it, but they don't really care that much. But when they talk about some problem that they had, it's very tough.
But that's why I think it's good to maybe present both types of stressors.
Yeah.
In the same stress profile.
Right, it's true. It's best to have different types of stress. For instance, another person that I did a stress assessment with, they didn't have such a response with the talking about a stressful event, but the serial sevens, when I asked them to do the subtraction by 7, they didn't get one answer right. And they started crying because it was so stressful for them and embarrassing they couldn't do one. And I felt like the worst person in the world for making them do this. But, so the different people react different to the same thing. So you don't know what to expect. You're going to find very different situations with different people that you work with. So, there could be a study that shows that this is what they found, but when you do the tests with the people that you're going to see, you're going to see many different situations. I did a stress assessment with my father when he was alive, and I did a stress assessment with my mother. The same stressors and everything. His was like hardly any reaction, perfect recovery, and hers was all over the place. And it made sense to me because he was very, dealing with problems, he was very easy, you know, and she used to call him Mr. Cool because it was like, she would be saying, oh my gosh, this is terrible, and he was like, calm down. And he didn't study biofeedback, he was just naturally like that, I don't know. And this is just talking about the emotional response specificity, and that it can be associated with unique changes in the physiology. And those are references. So I think for the PowerPoint on this, that's it. And then to make it real now, we will do real stress assessment here. It's a little different than what it would be normally, you know, in a real clinical setting, partly because the person who's the subject, sometimes in the seminars we might also have it so that they can see what's going on, so that they can learn. So I just want to show in here, if there's a couple of ways you can do it, but under Quick Start even, if you go to Quick Start, and let's see, do I have the demo? Yeah, we'll call this one. And you see under the physiology suite, you see stress assessment, 14-minute. So that's the one. And we would just select OK.
I introduced the stressor either by the Stroop test or
so you're doing it manually.
Manually, yeah.
There's in this software there's something called, and in many of the biofeedback software, there's something called, there's usually a way to just record without any set amount of time, and then there's also a way to record with a set amount of time. This is what they call a script, because everything is preset. So you have certain screens, certain timing that's already preset, and you're just pressing the key to go to the next space. Then what he's been doing is not using the script, but just using a regular recording screen, but manually saying, okay, this is baseline, I just want you to relax, and then when the baseline is over, when he wants to introduce the stressor, you just maybe, I don't know if you're doing that, but you press a key for event mark, so that puts a time marker on the screen, and then you would administer the stressor manually. So he might give a Stroop test that's on paper or showing something on screen. Somebody might have a separate TV that they play a video, a stressful video to watch. I know somebody was doing some research, and they had where they were doing a video of the opening scene of Saving Private Ryan or something, and which is very intense, even for someone who has not been in the military or anything. But I watched it, and I never watched that movie again. It was pretty rough. But the way that they did it, it just seemed, for someone who hasn't experienced anything like that, it made it more real. And anyway, so then they had another video that was just sort of neutral, and maybe another video that was relaxing. So they were measuring heart rate and skin conductance, I think, during those different conditions, and doing some research. So that was, again, another situation where we created a script, because in that case they wanted it to be exactly the same for each subject that was being recorded. And they had different people. I'm not a researcher, so Dr. Palacios would probably give you more detail on it, but you want things to be the same, and you don't want it to be dependent on the person who's doing the test and so on. So they had different people administering the test, but they had followed the same script. So if they were doing it manually, you know, maybe somebody, instead of starting at exactly 2 minutes, maybe they start at 2.5 minutes or 5 minutes or something. So that was a way to keep it the same. Okay. So, all right, so now what we can do is we can go ahead and start doing the placements. Now, on this screen, it's showing where the sensors need to be plugged in. One thing on this equipment that's important is when you're plugging a sensor in, the end of the cable, it has this white arrow on it, and where that plugs into the instrument, there's a dot So there's a white dot on the instrument where it needs to be lined up. On yours, I think it's, because the case is white, the dot is black. So you have to line it up properly before you plug it in. If you try to force it in the wrong way, then it can bend the pins and then has to go back to the factory. Or sometimes if you're lucky, you can get a small screwdriver and straighten the pin and you save yourself having to send it back to the factory. I've done that many times. So for instance, if we don't know where to plug the sensor in, we look on here, this is a respiration sensor. So I would see I plugged in, the one that says G is abdominal respiration, and then the next one would be H for thoracic respiration. We're only using the one for now. So we would plug that into G, so I just take the cable, line it up with the dot, and then I plug it in. Now, very helpful what Dr. Palacios did, unplug everything and lay out the cables separately, because otherwise they become spaghetti. So this is the respiration sensor. Okay, so she's gonna do the hookup.
Yeah, but that's it.
And
Stand up, okay. Hold your breath.
I have a bigger belly, remember?
And with this, they have an add-on piece that if you need more length, you can.
Where are you going to put the sensor?
On his right hand.
Did you test?
This one. On this one.
In the left one. In the left hand. The test.
Sorry.
Yeah, we did the test yesterday.
So he's
She knows already, yeah.
You kid a lot.
It reminds me of my college professor.
I'm beginning to know you.
I'm more comfortable.
Okay.
So he's
You're not making any joke?
No, I'm not
Okay.
making
No. Remember,
I have to do the hand?
Yeah.
Okay.
you have to clean only the part of the finger. You do not need to clean all the hand.
Okay.
Or the hand.
For that? I mean, for this?
Yes. First.
Oh, well, the gauze maybe is better.
Because
Let me get-
that might
Let me
leave
get-
fine.
We go for the green one and
So,
this directly to the health hose, but a very small amount of gel, very small amount.
I'm an assistant.
Yes,
Here's some gauze.
thank you so much.
you're a good assistant.
Can we do the front count?
Sure.
Remember to rub. That's enough.
Maybe we can just do one EMG
Can you rub
on the frontalis.
these two fingers?
Here and here.
Alright, that's it, and then
You want to choose one? I let you choose. I let you choose.
which one?
In fact, I am going to hold them. Okay. On.
Temperature?
You want to do temperature? Here it is temperature. And then you just pass. With the alcohol pad, you have to clean the residues of the last preparation.
And I'm wondering if that was too recent.
Well, the discussion about that is just if we're cleaning the sensors with the alcohol pad, it's better to clean it with the one that's not abrasive because
Yeah.
the abrasive is going to rub off some of the surface.
Because the
sensor.
surface is covered with different things. This is
It's-
a preparation which is a silver, chloride, and silver. And you call this silver chloride. And this does a better conductive material.
Oh, okay.
So you have the base metal, and then you have a coating of silver chloride.
Something more than that.
And over time, that coating gets wiped off.
Yes.
And then it doesn't work as well. It still works, but it doesn't work as well.
In fact, that's
That's too much.
no, that's okay. There's a certain number of uses in each sensor. 100 uses. But by looking at you have you.
This one?
Right, because even though they have that number, if somebody's using abrasives to clean them, maybe it lasts 1/4 of the time it should.
Yes. Yeah, that's correct. It's important to clean because since you are recording conduction, if the sensor has too many dirt, then there's going to alter the conduction. The speed and the amount of the pulse. Now you have that, you have to follow the.
So shouldn't have stuck in the other one?
So this is part of why you have to do the so many sessions practice,
Yeah.
so that when you're working with the real patients, it's very comfortable and it's faster. And they don't say, "Do you know what you're doing?"
Yes.
Yes.
Is this the first time you did this?
Exactly.
That you know what you're doing.
Would you like to cover that one?
E.
This one
The
was
skin
the-
conductance, yeah.
Yeah.
Let's see what you do.
I do the tape, yeah, I'd like to. Is that okay? I noticed when it was done on me, is that too fun? Is it okay to cover it?
Yes, but not too tight. And only when with one
One round.
one round. No, no,
No.
no.
But is it okay not to cover it?
No, because part of the sensor is picking up the room
The room
temperature,
temperature.
and the other part of the sensor is.
So this is the first screen that we get, and maybe, can everybody see okay? Now maybe we should move him back a little bit,
Yeah, I think
because he doesn't look so comfortable.
he looks like he's trying to look.
Yes, he's trying.
He's trying to
Okay.
see.
We have to avoid that with the patient.
And so, you know, that's one of the things you start to notice. Do they look comfortable, or do they look uncomfortable because of something that you could fix, you know? So this is showing you an outline of what's going to happen in the stress assessment. And I would usually go over, not all of these details right now with the person, but I would be explaining to them before we started, I'm going to put some sensors on. It's going to be measuring how your body reacts to stress. And I would also explain to them that there's going to be times that I ask them to do a task and other times I ask them to relax quietly. Because many times if you don't explain to them, they're going to be talking to you during this and it messes up the results. So the first part is going to be baseline. Then you have the color words, which is a stressor, and then rest 1 is a recovery, then the math task. Rest 2 is another recovery, stressful event recall, and then rest 3 is the last recovery, and then I would get the save the data and go over it with them. So at this point, you have your instructions and you have the signals here. Now, at the bottom of the screen, it's saying press A to Z or spacebar to continue. So I usually just use the spacebar all the time. So I press that.
Baseline.
And this, it says baseline, but it also on the bottom of the screen says verify signal quality and press the key to start. So what you want to do before you actually start going through the whole thing is look at your signals and see if they look okay. Now we can see this is the blood volume.
We have eye blinks, which is not natural because of the.
That's on the EMG.
That's on the EMG. There are the eye blinks.
And then here you have temperature and skin conductance. So part of what we're looking for is, does it look like a reasonable reading? So if I'm measuring Fahrenheit and I see a temperature of 20, I think something is wrong. Maybe this setting on the software got changed to Celsius and I have to go back and change it. Or if I saw a reading of 300, I know something is wrong. You know, or 1, I know something is wrong. So this would be the time to go back and fix that, rather than take this person through this whole assessment and say, oh my gosh, and made a mistake,
did it
I have to
wrong.
do it again. They would, it's first of all, they just took the test, so doing this exact same thing again right away is the stressors are not really gonna work that well. Their baselines are messed up, and they're frustrated because they just did it. So it's good to make sure everything is working okay. You can also do things to check to make sure there's some response. Like, I might ask him to just take a breath and see if I see change in the respiration. Now, while I'm doing this, I wouldn't have him looking at the screen.
Mm-hmm.
I would be looking at the screen myself and just ask to do those
Well,
things.
does the patient know? Yeah, and right now we saw an artifact due to the movement in the BBP sensor.
Mm-hmm.
Can you do it again? Please move your hand, your left hand.
Yeah.
Okay, there's an artifact. This is not the real measure. This is a consequence of the movement of the hand.
So that's another reason to to instruct them to
Not
keep
to-
their hand still. Now you can probably see it a little bit better. Take a breath.
Okay, yeah.
Mhm.
And also the other thing is the time. It's only 5 seconds, which is a very short time to be looking at a breath.
Yeah.
Yes.
So
It's
it would
1
be
minute.
more reasonable to have it on a minute.
So you
Okay.
can see
So there's-
several.
So there's some of those things that are not quite the way that you would normally have it set. So if I do a minute here, it changes everything, including the EMG and all, but you can see the breath much different.
Yeah. Okay.
Or half a minute, 30 seconds.
Yeah, you can see the breath differently.
Okay.
So every time he talks, for the EMG, every time he blinks, that would create these
Yeah.
spikes.
The spikes are due to the blinks, eye blinks.
Mhm.
Okay, alright. Oh,
And those are things you want to take into
Okay.
consideration.
great.
Okay, so now I'm going to go ahead and press a key to start. So I'll press the space bar. And what I normally would have said is, before I press the key, I would say, okay, now for the next 2 minutes, I just want you to relax. They may ask you, can I close my eyes, or different things, and you can say, okay. And again, I'm not giving any specific relaxation exercise or instructions, just to relax for the next 2 minutes.